Okay, good afternoon, everyone. Welcome to the House Human Services Committee. And this afternoon, under our Oversight and Accountability section, we are going to be hearing from Kelly Doherty, who's the Deputy Commissioner at the Department of Health, specifically around the Recovery Resident Certification Program that this committee put in legislation last year and passed the House and Senate and signed into law by the governor. And had a pretty aggressive time frame, and looking to update the committee on what is happening with that, any barriers that the department is experiencing in implementing it, and the general information. So you will find a copy of the report on our House Committee webpage. And good afternoon, Deputy Commissioner. Thank you for being here today.
Good afternoon, Madam Chair and members of the committee. For the record, Kelly Doherty, Deputy Commissioner at the Department of Health.
And we're going to do just a quick introduction since this is your first time in our committee this session, and we have lots of new members, and so you know who is sitting around the room. Welcome again, Teresa Wood from Waterbury, also serving Bolton, Gisborne, and Huntington.
Hi, I'm Ray Garofano. I live in Essex and also serve Essex Junction.
Jubilee McGill, I serve Bridport, Middlebury, New Haven, and Research.
Hello, my name is Zon Eustis. I serve Guilford and Vernon South.
Good afternoon, Todd Nielsen. I represent Brandon and Forestdale.
Doug Bishop, I represent Colchester's Chittenden 20 District.
Representative Steady, Westford, East Milton.
Good afternoon, Representative Eric Fly, Rutland City.
Good afternoon. I'm Dan Noyes. I represent Wolcott, Hyde Park, Johnson, and Belvedere.
And Donahue from Northfield, also representing Berlin.
Then we're going to go right around the outside.
Candace Gale, Director of Community Relations for Vermont Foundation of Recovery. Any folks, action circles?
I'm just Aaron Flint's
Great.
just a public.
Happy to have you here.
Jessica Shapano, Public Health Policy Director at the Vermont Department of Health. Natalie Wild, Department of Health. And Lori Morse, Committee Assistant.
Great. So Deputy Commissioner, we have arranged for, excuse me, have this recurring tickle in my throat, so my apologies up front. We've asked Natalie to sort of screen the report as you're talking about it, so that people watching us in YouTube land can see the report and hear you speak at the same time. So the floor is yours.
Great. Thank you very much. I would like to start out, particularly since we do have a lot of new members on the committee, to just sort of level set around what a recovery residence is, and distinguish it from other recovery related services in the community. So recovery residences are basically sober living environments for people who generally are in early recovery, and would benefit from a living situation with other individuals who are also in recovery. And it provides a lot of peer support, as well as connections to community-based services such as outpatient treatment, medication for opioid use disorder, other kinds of supports, maybe employment services, and then community-based recovery services. So I want to distinguish the recovery residents from the network of recovery centers that we have across the state, because sometimes those two things get conflated. So recovery centers, on the other hand, those are local nonprofit organizations that have a brick and mortar home base, and they provide a wide range of services for folks in recovery or pursuing recovery, including support groups. They have drop-in sort of activities, they have events, community gatherings that are substance-free to support people in recovery. And they also do recovery coaching. So you may have heard of peer recovery coaches that sort of, they're people with lived experience who help people sort of on their recovery journey. And another important piece of that work of the recovery centers is we have recovery coaches that will present at the emergency department. If someone is at the emergency department because of an overdose, or even if they are there for another reason, but disclose that they are struggling with substance use, a peer recovery coach can be deployed to the emergency department to support that person and help them connect with services in the community. So although there's a close connection between the recovery centers in the community and recovery housing, they are two distinct entities. And I'm happy to answer any questions if folks have questions about that.
Anybody have any questions? You've explained it very clearly. I was just asking that question myself earlier and making sure I understood the differences.
Yes.
So I don't see any hands going up, so thank you.
Okay, sure, great. So I will go ahead and just sort of walk through the report. This was obviously a report required by Act 163 of last year. And the department did significant sort of stakeholder engagement around this report and the certification program generally for recovery residences. And you'll see at the very end of the report, sort of in an appendix, sort of some of the actual input that we got from stakeholders. There was a lot of agreement among stakeholders regarding the certification of recovery residences and adopting the standards of the Vermont Alliance of Recovery Residences. So the Vermont Alliance for Recovery Residences is a, what's the word I'm looking for? Not a franchise, but a
You say affiliate in the report.
yeah, affiliate. That's the word I was looking for. Thank you. Of the National Association of Recovery Residences that establishes standards for recovery center certification. And NAR, the National Alliance of Recovery Residences, is really the only federally recognized sort of certification standards for recovery residences. I just want to also note that there's no like standard definition of a recovery residence. There's no like federal designation. So there can be many models of recovery residences. And the Department of Health funds some recovery residences, but not all the recovery residences that exist in Vermont, and not all of the recovery residences in Vermont will necessarily be certified. One other sort of area of general agreement among stakeholders was that the certification of recovery centers should be a voluntary activity. So VTAR, the Vermont affiliate of NAR, is currently the certification entity. So they have been around since 2019. Prior to that, there was no certification body for recovery residences in Vermont. And folks from V4 and other entities really kind of got together and said, we want to, sort of establish, some standards and have a certification process. So VTAR was formed in 2019, and their certification requires that operators of recovery residences demonstrate adherence to the national standards. So they have to submit a lot of documentation. They have annual inspections. They participate in trainings, and they have standards around grievances, et cetera. So VTAR has been doing this work for the last few years. But it wasn't really codified in any kind of legislation. And I want to be clear that part of, and I'll get to this later, but part of what the department is recommending in this report is that we have the authority to select the certifying body for recovery residences. And that will provide us with the opportunity, should it be necessary, if there were concerns about VTAR's performance, or if for some reason the organization dissolved, that we would have the authority to appoint a new certification body. So that is, you'll see one of the recommendations that we're making in this report. One of the areas I said that there was a largely agreement among the stakeholders around things in this report, but one of the areas that that there was more sort of energy around was the ability to exit folks from recovery residences should they experience a relapse of use, demonstrate, violent or threatening behavior. That is something that they already have the ability to do through the waiver of recovery residences, the temporary waiver, I should say, of recovery residences from the landlord-tenant law. There is disagreement in the community around whether recovery residences should have to abide by all aspects of landlord-tenant law. So we do have that exemption in place temporarily until July of 2026. Some of the respondents in our stakeholder input expressed that not only is return to substance use and violent threatening behavior, those aren't the only reasons that they would like to be able to exit someone. If there are other illegal activities happening, such as theft or other things, and that's currently not allowable in the exemption, the temporary exemption that's in place right now. So that was an area where there was a lot of discussion and energy. So I wanted
Kelly?
to, yes.
Can I ask a question about that? So the exemptions that we provided in the act last year, I guess I was under the impression that those were in addition to whatever existed already. So my recollection was that people actually could exit somebody for illegal activity, for instance.
Okay, I'm not sure if that's the way it's worded in legislation. I may have to phone a friend and Natalie to see if she has that exact wording, but my understanding was that it was only violence and substance use that was a permissible.
I know that's what we put in the law, but it's like, do you have a question, Representative Steady?
I have a question. How do people that would like help learn about these programs? I know I love hearing people that have been in these programs and how proud they are when they recover. I actually know a few. And how do they learn? Like if I knew
Okay, so
somebody,
how do they learn?
how do they learn?
Okay,
Yeah.
Thank you.
Sure. Yeah. So oftentimes people will go to recovery residences from a treatment program. So treatment providers are certainly aware of the recovery residences in their area. We also operate VT HelpLink, which is a sort of a one-stop shop for resources related to substance use. So folks could always visit that website or call the phone number and get information about resources in their area. So there are various ways that people could connect to these programs. And then of course, we have multiple providers, but V4 is our largest one. And I know that Candace is in the room, but they have a website where you can see all of their residences and find out which ones are have vacancies and are accepting new members. So there are many different ways that folks can find out about these. And one of our goals is to really expand the number of recovery residences that we have in Vermont, so that they're much more geographically dispersed, We have some communities that don't have any, so we're going to be working toward that in the coming years, provided that our budget request is accepted. So,
Thank you.
sure. Should I continue?
Yes, thank you.
Sure. So we were also asked about recommendations that we would make for legislation around recovery residences. And what we are recommending is that we're given statutory authority through rulemaking to establish the regulations of recovery residences. And then, like I said before, to select the certifying body, to require recovery residences to have grievance policies, minimum requirements when responding to a grievance, appeal process for certification denial. So if a recovery home was denied certification for one reason or another, we want to have the authority to establish that appeal process, and other sort of programmatic policies and procedures. So you'll see that in the report, both on the page that Natalie is on, as well as at the end of the report in our conclusion section.
Representative McGuire.
Thanks. I think we might have sailed past this, but how many other states have exempted the landlord tenant laws for recovery houses?
That's a great question. I don't know how many states, but I know it varies a lot. And Maine, I know, changed their statute, and I apologize, I don't know the full extent of that. There may be folks in the room who do, but they were able to make a change in their statute that I've heard from folks was a quote unquote game changer. And then I know that New Hampshire, we were just there for a visit, their recovery residences are licensed in a different way, and so they're not subject to landlord tenant law. So I think there's great variation, but we could certainly look into that and see. I'm sure that Jeff Murrow from VTAR would probably have a really good sense of what other states are doing in this regard.
Thank you.
Mm-hmm. So let me see, where was I? So VTAR does receive funding from the Department of Health. They also receive funding from certification fees that the recovery residence operators pay to be certified. So they also get some funding for when folks are early in their recovery and may not have stable income or employment. We do have funds that were directed toward sort of what we call like a stipend for folks to pay like their first month of rent at the recovery residence until they can really, get on their feet and, secure employment and other things. So that funding does travel from the health department through VTAR to the residences. And that the funding that we provide to them is a mix of federal funds, that we get, Vermont State General Fund, and then also the opioid abatement special fund dollars. Is there a question?
No, we're good.
Okay. There is a section starting on page 6 that talks about models from other states, but it doesn't really talk about the landlord tenant issue. It talks more about how recovery residences in other states are funded. So you can see that on page 6. So a lot get funding from obviously resident fees and government funding, and then there's always donations and other things. So and then I do want to point out that in addition to the potential barrier of the landlord tenant law, another barrier that stakeholders referred to was lack of stable and predictable funding for recovery residences as a barrier to further expand their presence in Vermont.
Deputy Commissioner, are you, and you might have said this and I might have missed it. Are you recommending that it still be voluntary, or that if you're going to call yourself a recovery residence that you need to be certified?
That's a great question. We are maintaining that it should be a voluntary process. And in order to sort of distinguish, certified recovery residences from other non-certified recovery residences, that we refer to the non-certified recovery residences as sober homes and the certified ones as certified recovery residences.
Thank you.
I talked about VTAR. We recommend, I don't think I explicitly said this. I did mention that VTAR is the current certifying body. And we do recommend at this point that VTAR remain the certifying body for recovery residences in Vermont. We also recommend that VTAR or the certifying body set the certification fees and fee structures. So right now, VTAR charges $250 per residence and certification fee, but they are looking at a per bed fee rather than a flat $250. That is what NAR uses, and so we expect that VTAR is going to be exploring that in the future, using a per bed fee rather than the flat fee. VTAR does require that all residences have a grievance policy and procedure, and that residents are expected to engage in that process with the operator of the recovery residence before bringing any complaints to VTAR, and we support that process. We also, I may have said this before, but as part of the recommended rulemaking authority for the department, we would like to be able to establish the requirements for the certifying body when responding to a grievance. So for example, setting the standards for that. So for example, like how are grievances submitted? What's the time frame that they would have to respond to a grievance? Data that would be required to be collected around grievances and reporting requirements, and then process for appeal of the outcome of the grievance to the department. So NAR does set out different levels of recovery resident certification, and there's a chart on page 10 that sort of outlines the different levels of recovery residences that NAR supports. And you can see that they kind of move from, very peer only focused, no paid staff in the residence, all the way up to a much more intensive, environment. So I would say that most of the recovery residences are not at the level 4. They're probably more like the level 2 in Vermont. So, and like I said before, these standards are the only nationally recognized standards for recovery housing. Also, SAMHSA, which is the Federal Substance Abuse and Mental Health Services Administration, they identify best practices for recovery housing, and those can be seen on page 11. I won't read them out to you. You can read them, but really sort of outline best practices, one of which is the importance of certification, because it sets a standard of quality. As far as data collection, we want to be able to require operators to collect certain data so that we can better understand resident outcomes. And so you can see these here, sort of where are they being referred from? You know, are they criminally justice involved? Do they, what's their substance history? Have they engaged in recovery resident services in the past? So that's something that we would like to have a better understanding of so that we can monitor the success of recovery residences and, you know, the successes of their residents.
Deputy Commissioner, we have a question. Rep. Garofano?
Thank you. I was just curious about the data collection. Does the department and or the recovery residences have the IT infrastructure to, collect, report, and then aggregate and analyze this data currently? Or does that require like additional work and infrastructure setup?
I think that it probably varies greatly. I don't think that the infrastructure is fully there, and that's something that that we're going to be looking at. There's some work going on right now to sort of inventory the recovery residences and what kind of infrastructure they do have. So that's something that we'll have to look at once we get the outcomes of the inventory.
Thank you.
We also recommend that we get additional community input through the rulemaking process. That's one of the benefits of giving us rulemaking authority. As you know, through the rulemaking process, there's extensive community input. And so we would be looking for input on various things, but also on the policies and procedures that we think that recovery residences should have to have. So you can see here on page 12, defining resident rights while they're living in a recovery residence, having some kind of smoking policy, infection control policies, and then other policies and procedures such as like a financial agreement with the resident, detailing what is covered in the fees that they pay to the residence operator, refund policies, late fees, those kinds of things, and then drug testing policies, because one of the requirements of staying in a recovery residence is that you abstain from illicit substances. So there is drug testing that takes place in recovery residences. And then medication policies. So providing for safe storage of medications, and also that medications for opioid use disorder be allowed in certified recovery residences. There are some recovery residences, not certified, but recovery residences, or I guess I should say sober homes, to make that distinction, that do have abstinence-only policies that apply to prescribed medications. And that is not something that that we support in a certified recovery home. People should be able to access their medications for opioid use disorder or alcohol use disorder while they're living in a recovery residence. And then the discharge policies.
Just a second, Deputy Commissioner, I have another question.
Yeah,
go ahead, Member McGuire.
Underneath the drug testing, my concern is this, drug screens are medical tools to use gauge that are gauged for what needs to maybe change in the individualized plan. I hope that these drug screens are not going to be used as a fast and hard mechanism of discharge, meaning that the individual is tested positive for an illicit substance, therefore discharge is inevitable. Because again, these are medical tools to use and gauge progress or what needs to change in somebody's plan, not to be utilized as a discharge or loss of residence. So can we be assured that that is not going to be the case in this matter?
I don't know if I can answer that across the board for all residences. So that might be something I'll need to sort of get back to you on. What I can do a little reach out to our providers and see how they're implementing that.
Yeah, I'm sorry, go ahead.
No, that's all right. Go ahead.
No, I was going to just elaborate on just quickly. If the drug screen is being used to like gauge performance and there are scaled responses in place in regards to like, hey, you tested positive here, therefore the response is this, or whether we need to get you in another service to make any adjustments, that's practical and applicable. Again, my concern is that they don't get used as, hey, you test positive, therefore you discharge.
Yeah, and one thing that we do have that we're going to be scaling up is what we're calling stabilization beds. And we already have sort of some stood up down in your area, Representative McGuire, through Chad Vijay's shop. But having beds where people can go to if they do relapse in a recovery residence, because one of the things is that you want to protect the rest of the milieu or the rest of the residents, you know, from that substance use. So having beds where we could send someone temporarily just while they sort of get back on their feet and then can come back to the recovery residence. So that's something that we are trying to expand upon and as part of our FY26 budget that we'll be presenting on tomorrow. So we also want to be able to use those beds for somebody who maybe is leaving residential treatment and is waiting for a bed in a recovery residence. So it would give them somewhere to stay so that they're not, for those people who need that type of support, that they're not being discharged from residential into the community and while they're waiting for a recovery residence bed, and then, you know, they relapse because they're back in their previous environment. So so you'll see more about that hopefully in the coming year.
Terrific. Thank you very much.
Another thing that I just want to point out that, you know, when we're talking about the landlord tenant issue and sort of discharging folks from recovery residences, I just want to point out that recovery residences are really different than other types of private housing. So often recovery residences will be helping people to get their driver's license or to connect them with treatment services in the community or recovery services, or, you know, helping them, you know, get to appointments and other things. And that's not something that a typical landlord would do. So there really is a distinction there. It's a much more supportive, you know, environment than a typical sort of just somebody renting an apartment. So I just want to point out that distinction because, you know, it is very different than somebody who is simply in a landlord-tenant relationship.
Deputy Commissioner, that sort of prompts me with a question because the recommendation, as I read it, is that you know, that residents shouldn't obfuscate the fact that they are in a landlord-tenant relationship by use of terms such as tenant fees and things like that, or resident fees, and they should call it what it is. But on the flip side, I guess I'm agreeing with what you just said, that it isn't strictly a landlord-tenant relationship, but I'm hearing your recommendation that it be clear that the landlord-tenant laws apply as opposed to creating a permanent carve-out.
I think that one thing that we mentioned in the report is that we don't really have a whole lot of data yet on sort of how many people are being, well, we do have some data that we just submitted a report today, but we feel like we need a little bit more time to see how this waiver, temporary waiver, plays out before we have a particular recommendation around, you know, landlord tenant law writ large against recovery residences. So I think that we don't have a hard and fast recommendation as far as permanent exemption, but also put forward to consider other situations that would allow somebody to be exited under the temporary waiver, if that makes sense.
Excuse me. I understand what you just said. That doesn't seem to be exactly the way it's written, but I understand what you're saying. Yeah.
Okay.
Okay, I think Representative Bishop has a question.
Okay.
I guess I may be taking a different reading of it, so maybe more clarification would be helpful. I guess I viewed it as maintaining the status quo with the exemption until more data. And I guess I sort of read it with a leaning towards the potential of keeping the exemption in place. But what sort of data would you be seeking to gather that could inform a final opinion being offered on this question?
I think more data on number of people who are being exited and for what reasons would be helpful, as well as sort of what the final outcome is. Like, is somebody being exited and maybe using one of those stabilization beds or using something else that's in their safety plan? That's another thing that we encourage, is that any residents in a recovery home sort of have a safety plan so that, you know, they can say, oh, if I relapse or if this happens, you know, I would go to my parents' house, or I would go here, or maybe it's the re-engagement bed or the stabilization bed. So having more data on sort of what those outcomes are, I think would be helpful.
And do you think that will be, do you think that the 2 years that we have in the bill as it's in the act will be sufficient time to gather that data?
That's what we put in the report, was that we recommend that it stay in place until what's stated there, which is till July 1st of 2026.
Yeah. And so is there a methodology by which recovery residences are submitting that data to someone?
Yes, so
Okay.
they are submitting that data to VTAR, and then VTAR is providing that data to the department.
Okay. And then I remember during testimony, there was, I guess, differing opinions on whether there was this safety net that existed for people who need to exit the recovery residence. And, you know, we heard some providers testify that, you know, yes, they work with the individual to locate, and that in fact they have to have a plan, you know, that you were referencing. And then we heard testimony from other people with lived experience or advocates saying, well, that wasn't our experience. So I think that it's going to be really important that we have, I guess, factual information before we make a decision about whether that should be extended on a permanent basis or another 2 years, or, you know, whatever, or not extended at all. So and allowed to sunset. So that will be helpful to see in the next legislative session, sort of what data has been collected so far.
Yep. Understood.
Yes, of what we have right now, but I just, it's early still. Yeah, it's early. Okay, thank you.
Moving on, we talked about the voluntary nature. So I think that is, I'll just conclude by saying that, you know, again, you can see at the end of the report under the conclusion section, sort of what we're recommending be included in legislation, and the statutory authority that the department recommends we have through rulemaking. for those different areas. So you can see that I stated it before. And the rest is sort of the input from the stakeholders. And I'm happy to
you.
answer any other questions.
Thank you. Questions from people? I guess one of my questions is whether or not, I don't think we've seen it yet, but is there a bill that's coming forward with to implement those recommendations?
I have not seen one yet.
Okay.
I don't know if there's one that has snuck through that I haven't seen.
Okay. Alrighty. Yes, Representative Bishop.
Thank you. You referenced that there was, sounds like some fairly vigorous discussion on this question about whether landlord-tenant relationship exists, and there was some differing opinions offered. I read some of the appendix and saw some of those opinions shared there. With respect to the recovery residence operators themselves, outside of other advocates, was there a uniform opinion offered by the recovery residences themselves about this landlord-tenant issue?
I believe that the ones that we heard from, because we didn't hear from all of them, support the exemption because they recognize that, you know, some of those behaviors can really disrupt the safety of the entire house. So I'm sure you're going to be hearing from some of the operators in your committee. So I would encourage you to ask them about that.
Thank you.
Questions? Go ahead, Rep. Garofano.
Thank you. I was just looking at I know it's early yet as far as the data, the exit and transfer data report. I'm just wondering, is there a mechanism to review that data and gather input from providers that have like low number of exits to kind of figure out like what practices they have in place that could inform the other? And then I also wondered if you might want to consider putting a percentage of like the number, like what percentage of their beds are being exited. It would just be helpful to understand, like there's one that has a lot of beds, so they would have a higher number, but also wondered, like, could we learn from those that have a very low number of exits to see what they're doing, what policies they have in place?
Yeah, and I'll just mention that one of the recovery residence operators in the report is Springfield, and they're very new. So that probably is a contributing factor to their zero numbers.
Any other questions? All right, it looks like you've given us sufficient information on this, and so we look forward to working with you and with the relevant providers out there to make some decisions about this in the future, about where we go on a more permanent basis. So thank you for reviewing the report and the recommendations with us. Appreciate it very much.
Yeah, thank you.
Okay. Okay, committee, we have coming in next. Lori, are they going to be in person or on Zoom? They'll be in person? Okay. So we have Karen Topper and we have Max Barrows, who is a self-advocate. Come on in. I was just saying, we have Karen Topper and Max Barrows, and you open the door and you appear.
This is where you say we're psychic.
Yeah, we're psychic, right? Sarah, I was gonna say, you can grab another chair if you want to, if you're, are you ready? A little bit early, but I appreciate you being here. Pull the chair over, Max. Sit at the head of the table.
Bring the chair right over. There you go.
So, Green Mountain Self Advocates is an organization of individuals with developmental and intellectual disabilities and autism who support each other. They have support groups around the state, and I'm sure that Max and Karen will tell you about the organization a little bit before they dive into the purpose, which is to talk about age 13 and the impact on people's lives of the current reimbursement process for Medicaid services. So we'll do a quick run around the table because it's your first time in committee. And nice to see you both. Teresa Wood from Waterbury, and I also serve Bolton, Bucyrus, and Huntington. Go ahead.
I'm Ray Garofano. Nice to see you both. I live in Essex and I also represent Ipswich Junction.
Hey, I'm Jubilee McGill and I represent Bridgeport, Middlebury, New Haven and Weybridge.
Hi, I'm Rep. Esme Cole and I represent Hartford.
My name is Zon Eastis and I live in Guilford, representing Guilford and Vernon.
Good afternoon, I'm Todd Nielsen. I represent Brandon and Forest.
Welcome. Doug Bishop, I represent Colchester's Chittenden 20 District.
I know I see you in the hall. Representatives Betty Milton, East Milton, Westford.
Good afternoon, Eric McGuire, representative for Rutland City.
Good afternoon. I'm Dan Noyes. I represent Wolcott, Hyde Park, Johnson, and Belvedere.
And our ranking member will be back. Ann Donahue represents Northfield and Berlin. So, and then we'll just go around the outside.
Andy Wood today. I'm with Vermont Leadership Institute this time.
Oh, great. Welcome. There's Lori.
Lori Morse, Committee Assistant. Hi.
Welcome to both of you. Thank you for being here today. And the floor is yours. So introduce yourself for the record. And folks, we do have copies of information on our website. So the floor is yours.
It's up to you.
Go ahead.
Okay, I can do that. Yeah, so my name is Max Barrows. I live with my parents in Worcester, Vermont. I've been the outreach director for Green Mountain Self Advocates for 17 years now. I am a person with an intellectual and developmental disability, and I am on the autism spectrum, and I receive developmental services. In my role, I mentor people with intellectual and developmental disabilities who are part of, peer support groups across Vermont. A quick lesson on self-advocacy. The first step to speaking up for yourself is understanding your disability, to know what you do well and what you need help with. For example, I can easily say, I have autism, but admitting when I don't understand something is harder. I worry that people might think that I'm not smart. Many of us find it easy to talk about what we can do independently, but it takes courage to be honest about what we need help with. Building trust with a new support person takes time. My confidence grows when I have a strong, familiar team that listens and supports me. Losing trusted support staff can be devastating. I rely on my team for advice and reassurance. My emotional well-being, physical health, and success at work all depend on having a consistent, reliable, and stable support system. In April of 2022, the workforce crisis directly impacted my life. My support person, who had worked with me for over 6 years, had to leave for a higher paying job to support his family. I was fortunate to have a supportive family. My dad, a retired teacher, stepped in as my volunteer support person. Because of him, I was able to continue working successfully. What you need to know is that for 13 months, I had no support staff. Eventually, I switched to a different agency in my county, one that was more accountable and met my needs. But I'm not the only one who has gone, a long time without services. The system is under pressure. Many people with disabilities experience high stress because staff leave, so often. Just when we build a strong relationship with a support worker, they leave for a higher paying job. This is painful and sets us back. Thank you for your hard work in writing and working to pass H13. This bill is an important step toward making funding for developmental disability services, DDS, fair, stable, and data-driven. The way I see it, H13 will ensure we get the services we need, pay providers fair rates based on real costs, and improve tracking of how public money is spent. Other states and some of Vermont's other Medicaid programs adjust payment rates each year based on real costs. H13 establishes a clear and fair process for setting rates for home and community-based service providers and designated and specialized service agencies. We truly appreciate the committee's efforts to stabilize our service system. For the past 5 years, many of us have struggled without staff due to the COVID-19 and the workforce crisis. This has made self-advocacy harder. The ripple effect is that now some of us hesitate to speak up when staff are disrespectful because we fear that if we do, we might lose our staff and go back to having no staff at all. H13 is not just about funding, it's an investment in people with developmental disabilities. It will increase access to job support, which is essential for economic independence. Right now, the state reports that 48% of people receiving services have jobs and pay taxes. But many want to work and cannot because of a lack of support. Others work only a few hours a week, but want to work more. When we work, people see our skills and contributions. Stabilizing pay rates for support staff is a smart investment because the more we work, the less we rely on government benefits like Social Security, and the more we make real contributions to our communities. In closing, I will quote my co-worker, Chris Medina, who receives developmental services. And I quote, "Life after the pandemic has been challenging for me. I use supported typing to communicate, and I only have one support person to be my typing partner. I barely get out of the house to work and contribute to my community compared to my funded support hours." Chris gets less than 50% of the hours he is actually funded to receive. My fellow typing brothers of my peer support group are in a similar situation. The impact not having trained staff has, on my life means I cannot, have independence and autonomy. Time without staff is, time without communication. So losing a staff person is like locking up my voice and throwing away the key. I want to have full control of my life, with supportive staff. I need good staff to work and access my community, end quote. Thank you for taking the time to listen to our concerns. And we understand that you have many, many priorities and are working hard to support the needs of, so many people. And we appreciate your proactive efforts to pass H13 and improve the services that people with disabilities rely on. Thank you for your dedication and commitment to making a difference in our lives.
Thank you, Max. Any questions for Max? Thank you for also for bringing the words of Chris to us as well.
Yeah.
I appreciate that. And it would be lovely for the committee at some point to experience an individual who uses supported typing to communicate, if we can find somebody who's willing and has the available support to do that, which we understand is in short supply these days. So I'm curious, Max, if you have you or any of your friends or colleagues that you work with have any idea about whether this is unique to Vermont, whether this, I know you get around other states and you do national work. I'm just wondering, is the problems that we're facing here sort of Vermont born, or are they similar to problems that other people in other states are having?
I can tell you this. I think people are familiar to what's going on in Vermont, but we have to, kind of explain it in a way that they can understand. Sometimes the information about what's going on may not be as accessible for people to understand, but once we break it down, they do understand. I'm not sure as much about the national scene.
Well,
I
Max.
mean, I think that I can say that it is like across the country, because I know that when we have people we talk to on a national level, they do express also that, especially since the COVID-19 pandemic has occurred, they've felt isolated and, just all the rules changing, and also some people losing staff on a national level, that they just feel like they can't do anything. And I know that with calls that we have national meetings that we hold like a couple times now. It's once a week. It's a safe place for people to kind of express what's going on in their lives, and then some of the topics that are generated from the the calls that we have, come from individuals, just based on what's on their mind and what's affecting their lives and stuff like that. So if there's any kind of awareness, it's directly from their perspective more than systemically, which, I'm more in tune with.
You're hearing people's, what I'm understanding you to say is that you are hearing people in those calls that you have express frustration with the fact that they too don't have the necessary support staff. Is that?
They don't have they don't have the necessary support staff. And then in addition to like other, things that have changed over time, we were dealing with, the time of uncertainty with COVID, just not being out in the community as much, doing the things that they like.
And I think, Max has done a great job of, it started in March of 2020. We just like spontaneously started to have Zoom meetings twice a week at that time. And within a very short amount of time, because we do some national work, there were 50 to 100 people that on these calls, and we still meet once a week on Thursdays at 1:00. And there's still at least 50 people that come to the calls, and they're from upwards of 35 different states. Not everyone comes every single Thursday, but they'll, somebody from Alaska will check in at least once a month, or somebody from Oregon or the different states. One thing we have heard is that there have been in New York and Minnesota, there have been other states that have gone down this road of having, rates. Teresa, you're probably more for, Representative Wood, you're probably, okay, thanks. I know Teresa for too long, since the early 90s. So, excuse me, but anyway, and I didn't introduce myself yet. Oh boy. Okay. Anyways, to finish my comment is just that there are other states that are going down this road of having, rates, and then also going down the road of having where they're adjusted every year. So we're very pleased to see that also here in Vermont. For sure.
Well, and one of the things that we heard testimony on earlier, not today, but maybe last week or the week before, was the contract for people who hire their own workers. A contract that was negotiated, a collective bargaining agreement, so a union contract essentially. Everybody signed on the dotted line for a minimum wage, a base wage of $14.75, which seems insufficient to me and for people doing direct support and services for individuals. So they've had to, if you pay more, which you have the ability to do, you have to reduce your services in order to pay more if you're managing your own. So I didn't know if there's anybody in the network, in the GMSA network, who have, experienced that situation.
Not that I know of, but we certainly will keep an ear for it and bring you any stories that we do hear. I mean, to be honest with you, so first of all, I'm Karen Topper. I work at Green Mountain Self Advocates. Max and I have worked together since for the 17 years that he's been there. So, I mean, to be honest, Teresa, sometimes if people like the idea of having a base rate, but also like the idea of being able to pay more, having the option, the flexibility to pay more, even if it does mean that they would get fewer hours, because it's better to having a really good quality staff person and have them for 15 hours a week than, maybe not have someone, or not having anybody at all, or for a long time, or having someone that, is not as good, not as trained as well to be able to work for 20 hours a week, let's say. So I think some people do like to have that flexibility. So.
Thank you. The other thing that, the department has proposed over time is the concept of paying parents as providers. And I'm just wondering if Green Mountain Self Advocates has a, I don't know if we call it a position or has some thoughts about that. There are sort of, I guess I would say, varying things on the table of ways to help increase the amount of supports that people are receiving to help them get closer to their authorized plan. Paying parents as provider might be one of those things that gets proposed. And I'm just wondering what Green Mountain Self Advocates thoughts are about that.
I think that the safeguards that they're proposed seem acceptable to us.
Mm-hmm.
So, I mean, it seems to me that we watched the committee and they've come and talked to our board, and we're kind of pleased with the safeguards that were put in place. So.
Yeah, I mean, I agree.
Do you have particular thoughts that you want to share?
I'm Karen Topper. I live in Barre, Vermont, and I work for Green Mountain Self Advocates. So I wanted to give you two kind of small examples of the work that we do. We recently, or the past year, have hired and trained 13 people with intellectual disabilities to serve as peer mentors. And these mentors use their lived experience and expertise to train and support their peers in understanding their rights under the home and community-based services. So the funding comes from the state of Vermont. It was some of the FMAP money. It's some of it's a limited project that we're under contract for. And one thing that we're pretty well known for is we've taken the information from, so the home and community-based services, they have rules and that the providers have to follow that really protect people's rights. And so we've used these peer mentors to teach about these rules and people's rights, but we've done it in such a way that we've created a lot of plain language resources so that people can understand it, because a lot of times the policy stuff is difficult for people to understand. Another example of our work is that we support people with intellectual disabilities to serve on more than 20 state and national committees and boards. And in fact, one of them is the Payment Reform Advisory Board that we've supported people to be part of over the last few years. So, and this committee is the committee that's worked on for quite a while now to come up with establishing or propose the different rates that would be used for developmental services.
Just a quick question on that. Is that in Vermont?
Yes.
Is it, so it just is thinking about the reforms for Vermont?
Right.
Okay, perfect, thank you.
We can be glad, I'm sure Representative Wood, or we would glad to share with you.
It's on our oversight and accountability agenda.
And so one of the roles that we play is to make sure we meet with people before the meeting and after the meetings, and we take a look at the information that's being shared to make sure that it's in plain language. So make sure that the information is cognitively accessible, because how can people contribute to the committee and be able to help in the decision making if they don't know, they don't understand what's being said in the meetings. And to be honest with you, a lot of times we share our plain language information with other people in the committee, and they appreciate our plain language translation of some of the policy information. We want to thank the members of this committee for your hard work to write and to get past H13. We feel that this legislation will really help follow the new Medicaid access rule. So last April of 2024, the Centers on Medicaid and Medicaid Services, CMS, the federal government, created a new rule called the Access Rule to make sure that people get the care that they need through home and community-based services. And actually, in this rule, it makes states set clear rules for how they're going to decide and change Medicaid payment rates for these services. It also requires states to review payment rates regularly and increase them each year to keep up with rising costs. By keeping better track of data and checking payments more often, the rule helps make sure providers get enough money to offer quality care to people who rely on these Medicaid services. And overall, the access rule is an important step in making home and community-based services stronger. It makes sure that Medicaid payment rates are clear, fair, and updated regularly to keep up with the cost of living. And this helps people who rely on Medicaid get better care and the services they need. So these access rules is another example of how we spent a lot of time looking at those access rules, and we actually did translate them into plain language. If anybody is interested to know, if we can share the link with you to our website. So, because we really want to make sure that people, when policies are made, like big policies like this Medicaid policy, want to make sure that people understand what's at stake here. So anyways, it's really great that H13, excuse me, is going to help you meet this federal requirement under Medicaid access. So for many years, Medicaid payments have not kept up with inflation, rising costs, and the needs of workers. And because of this, agencies that provide services have struggled. There's a big shortage of workers because direct support professionals, which is kind of a term that's used for direct support staff, and other staff just don't get paid enough. When wages are too low, it's hard to find and keep skilled workers. And this leads to frequent staff changes and makes it difficult for people to get the services they need. So many people with disabilities are missing out on support because there are not enough workers to cover all the hours needed. So H13 helps fix this problem by making sure Medicaid rates go up each year based on actual costs. It also creates a fair and clear process for deciding payment rates. This means that providers will get paid enough to cover their costs and keep up with rising expenses. Regular review of the payment rates will help agencies plan for the future. And actually, this is not a new idea. It's my understanding that since 2016, rates that are paid to nursing homes in Vermont have been adjusted annually based on cost and inflation. Correct me if I'm wrong, but that's my understanding. So a stronger funding system will also help keep workers in their jobs. When wages are fair and stable, agencies can hire and keep skilled staff. This means less turnover and better care for people with disabilities and older adults. When agencies pay competitive wages, they can keep experienced staff, leading to better and more consistent care. One very short little anecdotal story is, I know of a woman who's worked for an agency for 15 years, and her daughter started working in another agency in the same county and started working at a rate higher than her mother had been after she'd been working at this other agency for 15 years. So having this the rate study that's been done and having that all go into place in October is going to be, I think, really a step towards fairness. So when agencies pay competitive wages, they can keep experienced staff, leading to better and more consistent care. It also saves time and money. Hiring and training new direct support professionals is very expensive because many DSPs leave their jobs quickly. Agencies have to spend even more money to hire and train new staff. This is why it's important to find ways to keep workers longer and pay them their wages. H13 also improves fairness and accountability. The bill requires yearly reports to lawmakers so that you can understand the funding needs and how services are being delivered. This makes sure Medicaid money is used for direct care and not just for administrative costs. And by collecting better data, Vermont can make smarter decisions about where funding is needed most. Another little short story is just that I think this is really important. Right now, we can't keep, we need to have data to show so you've voted for all this money to go into the system. Well, how much is really being delivered? So this is going to be able to give you the data that's going to be able to show that. A lot of the people that come to our self-advocacy groups live on their own. Not everybody, most of the people actually live with their families, or live with shared living providers. But some people live on their own, and it's kind of one of the informal supports that they get. And, at a recent meeting, there was this man that I've known since the late 80s there. And to be honest, he didn't smell very good. It was obvious that he hadn't bathed in a while. And I was kind of shocked because I've known this person since 89 and what was going on here, and he also didn't look very healthy. And so, I kind of offered to give him a ride home, and he was reluctant, but he let me give him a ride home. And then I kind of talked to him about it after the meeting. And, it was like Christmas time. It was right after Christmas. And for some reason, his support person wasn't available. So he hadn't had anybody stop by his apartment to help him out for 2 weeks. And so, he was very nervous that I was paying attention to this because, he was afraid it was going to mean he was going to lose his independence. And, so we kind of made a plan, the two of us, to get together the next day and kind of, make sure that he was getting the help that he needed. But, there's an example of someone who has been living on their own for a long time, just having staff kind of stop by a couple times a week. And, if he doesn't get that support, he's going to need it's going to be cost a whole lot more money to take care of it, because, he's going to maybe need to go into shared living, which could cost $50,000, $60,000. It could cost a lot more money. I don't want to be quoted on that price, but it could be cost a lot more money.
More than what they're spending now.
Yeah, exactly.
Sure.
Way more than they're spending now. And he also could get really sick, because he not have somebody checking in on him. So it's just, I guess what I'm trying to say is that when we start to collect better data, we're going to have a better picture. You're going to have a better picture to know if there's pockets where people are not getting, they're just not getting as much services as other places, looking at the outcomes for the people in that area. Are people going to the emergency room more? Are they getting more? There's a way, once we have this data, I think that will really kind of help us make more informed decisions. So, anyways, I'm going to move on here a little bit. So, I think that, H13 is a smart investment in Vermont's future. It will ensure that Medicaid rates are fair, stable, and keep up with the cost of living. This will help strengthen the workforce, improve access to services, and make sure that state money is used wisely. We strongly urge this committee to continue to support H13 to keep Vermont's Medicaid funding services strong and sustainable. And that's what I have to say today.
Thank you. Thank you. And thank you for specifically mentioning the Medicaid access rule. We had testimony from the Agency of Human Services about H13. I don't recall them mentioning it, but it does seem like H13 would assist in, implementing some aspects of that federal rule as it stands, which we have talked about in the past about states need to assure that they're paying a sufficient rate in order to actually provide the service. And we were talking about that in the context of dentists at one point in time, and the state was paying an insufficient amount in Medicaid rates for people to be able to actually have dental services, even though it's a covered service in the plan. So thank you very much. So questions for either of the witnesses this afternoon? Go ahead, Rep. Garofano.
Not a question, just a comment. Thank you for all your efforts in the plain language. I think that is so important, and I wish more organizations across the state would do that, because I think it does benefit everyone. It's not just for a subset of the population.
Exactly. Thank you. Thank you so much for being here, and I appreciate it.
Thank you.
Come back anytime.
Bring Chris.
All right, that would be awesome. Okay.
General question about.
Yeah.
Have we gotten any language from the department saying invited them to?
No, however, I have had conversation, Ray's question was, have we gotten any language from the Department of Vermont Health Access on the proposed bill? We invited them to submit language changes. I had a conversation with their legislative contact. I don't know what their official titles are, but all the departments have them now. I guess we keep people so busy that they have to have special staff in order to connect with us. But again, they are honestly hoping that we don't pass H13, which was not surprising to me. They said, well, what I understood, it's being said, well, we can, submit a list of the schedule and, when the sort of planned rate reviews will happen. And I said, well, that'd be great. We'd be delighted to have that. But I can say also that when we did this bill 3 years ago, the same promise was made, and really there's not anything transparent 3 years later about the process. And so we will continue to work with the department on language that hopefully we can sort of all agree to. What they put forward as their concern is that we're singling out home and community-based services, and really the impact is on all Medicaid services. And I'm not sure if they really want us to say all Medicaid services, right?
Yeah, good answer.
I know. Not really sure that's what they want, but as we heard the witness, the Medicaid director, Ogilvy say earlier in testimony that their concern was, again, that this was singling out home and community-based services. And I again sort of put forward the concern is that we right now are only concentrating any kind of financial relief or any kind of rate review on the highest cost aspect of the service, which are nursing facilities. And as we know, there was 50-something million dollars, 54 million, something like that, in the budget adjustment for financial relief for those organizations. And as these witnesses just said, it's true that they are the only entity that has in statute a required review of their rates on a periodic basis. So at the very least, we should be looking at leveling that playing field. And, so it's nursing facilities that have that in statute now. The alternative for nursing facilities is home and community-based services. So that's why we were focusing on home and community-based services. It was a long answer to your question, Madam Vice Chair, but
Great.
the conversations continue. And I'm sure that we will get a proposal of some sort from them, which is what I asked for. If they don't, we'll see what happens. So I was clear that we were not entitling any specific appropriation, and we were really looking at a process to inform the legislature's actions. And even though they understand that, they still have some issues. So we'll see. Yeah, Doug, go ahead.
Is there any history or practice of having an agency or department come in and we ask them for testimony if they have not proactively responded or have not proactively, they have not responded to a request you've made?
Yes, we can have them back in the witness chair. I mean, I'll certainly be talking with them, we have this scheduled for starting markup, I want to say later this week. Am I right, Lori?
Yeah.
Yes, starting markup on this later this week. And obviously we want to work with the administration on making sure that we have a bill that is doable. One thing that people might not know is that they have a regular contract for an organization, an outside entity that does rate reviews. Home and community-based services have not historically been prioritized for that, or honestly, only if there's been, like 3 years ago, we had budget language that required a review. That did not require, I don't recall that required any additional appropriation because they have, like I said, an ongoing contract with an organization that used to be called Burns and Associates and it's called something else now. But they've been regular contractors with the state for reviewing and assessing Medicaid rates. So, to me, it's a matter of like, is this a priority? Set the priority. It doesn't necessarily cost any money. We're saying it's a priority because all we see is extra money being put into the highest end of the service system. So, did you have something, Zoe?
Well, I just need to understand. So there's this contract out to do rate reviews for Medicaid, but it sounds like then the department is or is not telling them which parts of the system to set or examine the rates on.
Yes, the department in Department of Vermont Health Access, in consultation with other AHS departments, sets the agenda for, what the work will be for that organization for, any specific period of time.
So what we're suggesting is that the agenda needs to be a broader in scope. Essentially.
Yeah, I mean.
Or pay attention to this. Bring it forward,
Yeah. I, just as an FYI, so I forwarded folks a copy of the link that the witness spoke about in terms of the federal rule on Medicaid, the Medicaid access rule, which is pretty interesting to read. So I suggest you read that as we talk about marking up H13 later this week. because there's requirements there that, you know, honestly, we might have the department back to ask, how are you meeting these requirements? It's a relatively new rule, April 24.
Mhm.
It was interesting, we didn't hear from the department about that rule.
Yeah, yeah. So we'll ask them about it. Yeah, on the record, I think we'll ask them about it. So, okay, yes, Brenda.
Do we get money figures for the changes? Like how much it's gonna cost for the additional?
Well, at this point in time, we would not ask for a fiscal note on this because our intent would be to say, these are priority services. So prioritize them essentially within your existing contract that you already spend money on.
Well, there wouldn't be any more money?
That's what I'm saying.
Okay.
The department is saying that there could be an additional $400,000 in cost. And I'm saying, well, let's talk about what you prioritize for the resources that you already have. So we're still having that conversation. Dan?
Do you think it'd be worth having somebody come in and kind of break this down, whether it's, I don't know, fiscal or ledge council, just ensuring access to Medicaid services final rule? I mean, I'll read through it, but just, I wonder if someone could.
Well, I think that what I will do, because it's the Agency of Human Services responsibility to comply with the federal rules. So we will ask them to come back and ask them how they are complying with this. And so the whole concept about prioritizing home and community-based services. So we'll seek to have them come back because we didn't know about this per se when they were here. So we didn't ask them about it. Any other questions? Any other people you want to hear from? We've heard from residential care. We've heard from designated and specialized service agencies. We have not yet heard from substance use providers, who are also now starting to get into the Medicaid, what would you call it? Yeah, I was thinking of something a little less flattering, but what is that? The animals that hamster wheel. So, what do you think about that, Eric?
Well, that's what I was going to introduce for our discussion to kind of introduce, and we also, Julie and I spoke in regards to the expanding that and looking at in regard with Department of Substance Use to where we can adequately fund them to maybe expand their treatment with inside the facilities up to 30 days, whatever that looks like. To ask to where that could possibly be introduced into this bill, or is that something we should lay off on? I think we should pursue it because we're going to look at it across the board, then let's look at it across the board.
Well, I think we should definitely include them in the definition of home and community-based providers. So that would, when they are Medicaid providers, that would make sure that they're included in that regular rate review process. And of course, they'll have to establish an initial rate when they, excuse me, when the services first start. But yeah, I think we should include them in the list of home and community-based providers. So what I'm thinking about, and I don't know if Jen is going to be here in a little bit, but
I asked her to come.
If she's able to.
It's gonna try.
Okay. So I'm thinking about that. Yeah, I'll take one of those. Thank you. Thank you, Todd.
My pleasure.
I have this, pickle thing. Yeah, I mean, I think that what we're trying to do is to assure that community-based providers get the same kind of attention as our institutional providers. Hospitals have their rates reviewed, insurance companies have their rates reviewed, nursing homes have their rates reviewed.
And so do even physician groups and so forth.
Exactly.
So all of those rates
Yeah,
come on a cycle.
and these are rates these are services that are alternatives to those things and less costly alternatives. So why would we not want to assure that people could actually access those services? So, So, oh, yeah, I was just gonna give people a small break, but that's okay, you're here. I want to make sure we make good use of your time.
This is hundreds and hundreds of meetings.
Yeah.
Give us a report tomorrow morning.
Let's look at the executive summary.
That Green Mountain Self Advocates, language guide that they did from the rules, so that will be easier to.
Yeah, I like it. It's got picture. So much more engaging.
You speak to Chad.
You want a mad dash today?
Be able to give the book for instance in regards to that.
Yeah. I'm happy to have him come in, or if you want to, he's, I'm sure, thinking about what the future holds for Medicaid rates for recovery providers. And it seemed like it would be short-sighted to leave them out.
Yeah.
We know,
Absolutely.
we know that it's going to be something that's added to the state plan. So I think we should include them. But in the meantime, what we have is, there was a state Supreme Court lawsuit that was filed on behalf of an individual with developmental disabilities who had appealed to the Human Services Board, essentially because they were getting insufficient services. And so I'll let Jen sort of explain the background and then what happened as a result of that. So again, there's all sorts of things that are happening in the outside circle that actually support, I think, our work on doing this H13. So the floor is yours.
Great. Good afternoon. Jen Carby from the Office of Legislative Counsel. And I don't know, Madam Chair, do you want me to put the opinion up on the screen?
Sure.
Okay, so.
Yeah, and then, send it to Lori.
I did.
Oh, of course you did. Oh, yeah. So read the Green Mountain Self Advocates version.
Yeah.
I understand that they had done the consumer version of this. Yeah, easy to understand.
Much easier than
Yeah.
Medicaid guide.
Yeah.
CMS.
Right. Put this.
And you sent that to Lori too, so let's post it on the webpage, Lori. Yeah, okay, thanks.
You're in that.
Yeah,
She's of that too.
the Green Mountain Self Advocates. Which one? Yeah.
All right, so we are looking at a Vermont Supreme Court decision from last fall. I believe it was from October of 2024. And this is, the title of this, you can see over on the left, is In Re Appeal of KM. And it is in the Supreme Court, Vermont State Supreme Court, on appeal from the Human Services Board. And in this case, they were looking at whether the Human Services Board that hears appeals and hears from people who are not satisfied, having some problem with the services that they're receiving from some of the departments within the Agency of Human Services. They were considered, the Vermont Supreme Court was considering whether the Human Services Board can grant relief to a person with disabilities who is not receiving the services to which, in this case, he is entitled. And so he is supposed to be, KM, is supposed to be receiving more than 30 hours of support services each week. But since March of 2020, he has received no more than 5 hours of services each week. And so he and his attorneys petitioned the board seeking an order directing Dale to provide all of the services to which he was entitled. And the board dismissed his petition for, they said, failure to state a claim on which relief can be granted. It goes into it a little bit more, and things that may be of interest mostly to attorneys around procedure. But so the things to know, and you know, it's sort of addressed this in the summary, but for more than 20 years, this individual, an adult with disabilities, has been receiving Medicaid-funded home and community-based developmental disability services. So some of the services we've been talking about in the context of H13, provided by Washington County Mental Health Services, which is one of the designated agencies. And as it said at the outset, he is supposed to be receiving more than 30 hours per week of community supports, but since March of 2020, he's been receiving only 2 to 5 hours of community supports each week, and this has had various negative health outcomes or effects for him. It talks about Washington County Mental Health Services, which is a member of Vermont Care Partners, and that those agencies, the designated and specialized service agencies that comprise Vermont Care Partners, collectively report their staffing shortages and vacancies, and they report, as I'm sure is no surprise from what you've heard in here, high staff vacancy and turnover rates for positions that provide care. And a study of that workforce here in Vermont found that low wages contribute to departures from the profession. So then the decision goes on to say, even though it's Washington County Mental Health that's providing the services, it's ultimately Dale who is responsible for all Medicaid-funded developmental services in Vermont. Dale is the one that allocates and disperses Medicaid funds for the services, which are provided by the designated agencies and specialized services agencies. And then it talks a little bit more about Medicaid. The Federal Medicaid Act requires that state Medicaid programs, and this is taken right from federal statute, provide that all individuals wishing to make application for medical assistance under the plan being the Medicaid state plan, shall have opportunity to do so, and that such assistance shall be furnished with reasonable promptness to all eligible individuals. And it talks about medical assistance as both payment and the care and services themselves, or both. One or the other or both. And then implementing regulations for that federal statute requires the designated state agency to furnish Medicaid promptly to beneficiaries without any delay caused by the agency's administrative procedures, and continue to furnish Medicaid regularly to all individuals until they're found to be ineligible. And then it cites some Vermont statute saying that Dale must, within the limits of funds designated by the General Assembly for this purpose, ensure that community services are provided. And similarly, for individual recipients, any person with a developmental disability shall be provided with services and funding within the department's available resources in accordance with both the system of care plan and the person's written plan of service. And if the recipient has a claim for assistance, benefits, or services that is not acted upon with reasonable promptness, then the statute on the Human Services Board says the board must grant the recipient a fair hearing. So in this case, KM, the plaintiff, asked the board to order Dale to provide him with all the services he's eligible for under state and federal law with reasonable promptness, which is that language from the state and federal law. The board found that his statement did not state a cognizable claim for relief because it was too vague to inform the department about what action it had to take in order to comply with an injunction. And it explained that an order directing the department, Dale, to provide services when there is no staff available to perform them falls short of informing the department of what would be required for compliance. The board also interpreted the plaintiff's request as seeking an order commanding Dale to address either the statewide staffing problem with the requisite urgency and or the issue of developmental services staff wages. And it found that any determination made by the board about the validity of Dale's policy would not affect the level of services that this individual recipient received, so the board could not grant any relief. And a fair amount of this gets into whether the board appropriately interpreted this Srefovich, I'm not going to get it right, versus Dale, a 2006 case. And the non-legalese version is that Dale and the board did not read enough context in that decision. So they took a statement in that decision and applied it more broadly than the court says was actually what was intended by the court in that case. So KM appealed here to the court and says that the board made a mistake, board erred in concluding it lacked authority to order Dale to provide the benefits that he is entitled to. It states the standard for review. And then the court agrees with KM. So the Vermont Supreme Court says to the plaintiff, you're right, the board did have authority to grant relief here. The board has the authority to order Dale to provide prospective benefits in the future to an individual who asserts that his services have not been provided with reasonable promptness as is required by state and federal statute. And then we get into this discussion about Hershfovich. And here's where the court says you have to read it closely, though, to get the nuance of what we said here. And they said, while the Human Services Board cannot issue injunctions unrelated to an individual situation, it does have the authority to provide appropriate relief to a claimant. So what happened in that case was some people brought a challenge saying that a policy change was illegal because Dale didn't go through the right rulemaking process. And the court said that was not a matter for the Human Services Board because the process by which the rules were adopted didn't have bearing specifically on these individual plaintiffs. So telling Dale to, first of all, it was not really within the scope of the Human Services Board to tell Dale it had to go through a different rulemaking process or follow the rulemaking process. And even if it did, even if the rules had been properly promulgated, they would not have affected these people's benefits. So effectively for those lawyers, they said, you don't really have standing here. All right, so then we go back and forth about different decisions that Dale and the board said supports their reading, and the court shoots all of those down. It goes on for a couple pages. Yes. All right, so then they're saying they're clarifying the scope of the case. I won't try to pronounce the name again. So their clarification of the scope ensures that the board can carry out the legislature's will. The legislature expressly authorized the board to provide appropriate relief, including retroactive, looking backward, and prospective, looking forward, benefits. And that decision does not curtail those powers. It just clarifies, in accordance with the Human Services Board statute, that the board can act only where the agency action affects the petitioner's situation. And so they said the board was wrong here to dismiss the petition. And they disagree with the board's conclusion that the relief sought was too vague. And they go into various ways people phrase things. But ultimately, the board concluded that an order directing Dale to provide services when there was no staff available to perform them falls short of informing Dale of what would be required for compliance. And the court says, we don't agree with that. Compliance with such an order is straightforward to determine. If the board orders Dale to provide KM with the services to which he is entitled, determining compliance with that order requires only a determination of whether he has been provided those services. And here's part of what really gets into H13. Dale's staffing challenges might make it more difficult to comply with such an order, but those challenges do not make the order unclear. And so because they concluded that the board did have the power to grant the relief requested, namely the provision of the hours to which he was entitled, the court reversed the board's dismissal of the petition and they remanded it. So they gave it back to the Human Services Board for additional proceedings consistent with their opinion. And so they didn't, because of their conclusion, they didn't reach another claim he had brought on appeal. And so it is reversed and remanded for further proceedings consistent with this opinion. I do not know if there has been an outcome yet.
I don't know, but we are going to have legal aid in. Who
brought the case.
So we'll find out.
Yeah.
So from the way you summarized the end, is it reasonable to assume that that an order like that from the Human Service Board, that Dale could then comply with it? It's individualized. Dale could comply with it just by saying, okay, we're giving this person their services by taking somebody else's, who is employed still, who hasn't left, and giving them, and then other people lose out, but they have to claim on their own.
Presumably, I mean, this decision is very specific to this particular case, this person's case. So, is it possible that that Dale could meet the needs for this individual client, and in doing so, take resources away from somebody else who would then bring a claim to the Human Services Board, potentially?
Go ahead, Doug.
So just so I understand correctly, was the holding that the staff challenges do not relieve Dale from providing the services.
That's how I understand
Okay.
it, yes.
Has this resulted in a number of other people filing with the Human Services
I
Board?
don't know. I think we get aggregate numbers from the Human Services Board. I have not looked at their current report. I mean, I think, to the question from Representative Donahue, could Dale satisfy this one client by taking services away from other people? I think if I were the court and another challenge got to me on the court, I would say you were on notice, you were required to provide these services to all people under, to all Medicaid beneficiaries under the federal law. So it's not necessarily appropriate to satisfy one obligation by failing to satisfy others. So what the court expected Dale to do, I do think there is some, if I were Dale, there's some room in the language about within what's, within what is appropriated, within the limits of funds designated by the General Assembly for this purpose. I think you end up with a problem where you're complying with state law, but not federal. Even if you read that as saying, if the legislature doesn't give enough funds to properly support the staffing required to provide all of the services to which Medicaid beneficiaries are entitled. And so even if there's an out there for Dale under state law, there still isn't, I think, under federal law.
Yeah, Son had a question, then Doug again. Are you all set?
This was wanted to ask for to intensify what you're saying about it tonight.
Okay, go ahead.
Is there, so the last thing you were just saying, and maybe this is a question more for you, Madam Chair, is there a question of whether there's enough funds being provided for the services? I'm understanding it is the funds may be there, but we just don't have the service providers.
That's what I was.
Yeah,
well, that's.
So I would think
Which
if,
is the issue about the rate that we're paying for the
Right.
services.
so that's the case, it
That's
seems
the
like the
nexus.
wiggle room goes away. In the language of the whole.
That's the whole nexus, is making that
Yeah.
connection.
Right.
The nexus of this court case with H13 is exactly what you just said. That
So that the board could, just by looking at a set of rates, could determine what could be paid, and right now they're not really capable of doing.
Yeah, I mean, they're not making decisions about the rate paid. But I can tell you that when we have designated agencies in here, that they will say that the rates are insufficient to provide the services and to hire the staff at a rate that they can hire them and keep them. And as we said, the collective bargaining agreement, signed for people who hire their own workers, signed it at $14.75 an hour. Now, if you were a person providing direct personal care to somebody who is not able to toilet themselves, not able to feed themselves, requires assistance to get in and out of bed and to be dressed, I'm pretty sure that nursing homes pay more than $14.75 an hour to do that same work, as do hospitals. And so again, it comes back to why are we focusing on home and community-based services? Because that's the part of the system that has not had attention. So one of the questions that I had that's now gone out of my head. So St. Bail's have a question that they want to
I
ask.
just
Go ahead, Ray.
comment, as do many restaurants and fast food workers, where you're not responsible for a life of a person or like their daily needs. So the fact that folks can now go and get jobs outside the direct service industry.
Yeah.
And hospitality and make several dollars more an hour.
I know what I was going to say now.
Don't have those kinds.
So I don't know if anybody else is receiving these, but I am starting to receive letters from constituents saying my daughter's hours have been cut in half. And, she doesn't really know why, because the plan hasn't changed. And I don't know that, the connection, if there's a nexus with this or not, but those are questions that, I wanted folks to have sort of the understanding of this Supreme Court case, because it does inform what action we take on H13. And it does also, because the legislature is mentioned in there in terms of our responsibility to appropriate resources. And how do we appropriate resources if we have insufficient information to base those decisions on? And that's what comes back to H13. So this has gotten more complicated since we did it 3 years ago. But honestly, the situation has gotten worse in the ensuing 3 years. So we will hear from designated specialized service agencies tomorrow, I think. And you'll be able to ask those questions directly of them. And we will also be hearing from legal aid and the long-term care ombudsman. And we're going to be, there first thing in the morning tomorrow. So we'll be hearing from adult day provider and a recipient of adult day services as well.
Just
Yeah, go ahead.
a context segue to what you were just saying is it's 7 years ago that my mom we were helping my mom pay for providers for that kind of work. And that was not through Medicaid, that was the general market for who you could find. And we weren't like, being exorbitant. So we were paying the going rate at the time, which 7 years ago was $15 an hour, and awake overnight was $20 an hour. So, that's
in the meantime, we've had
7 years ago, and
Right.
things
We've
have
got a
gone up
pandemic.
since then.
Yeah.
Right. A lot of,
Yeah.
we've had inflation with nobody's, anyway.
So it's an issue, it's an issue I think that we have some responsibility for addressing. And we'll see where we go. We'll see what the department says. We'll have them back in to kind of, react to the, to this case, also react to the federal rule on Medicaid access to services. After, I'm sure that they're listening to all of our testimony. So, okay, so we I'm switching topics now onto budget. I started to mention that the budget docs are out. It is helpful if you want to have printed copies because you can mark them up to get a copy from Tony downstairs because he can blow them up, make them a little bit bigger than what you see. Don't forget to look at the language, what we call the language piece, okay? Because there's always language in there affecting us and we have to kind of search for it. We have not received a memo yet from House Appropriations, but I'm sure that we will shortly. But, now that we have the information available to us, we should get started on that in any time that we're not in committee. Anybody have any questions? Yeah.
Yes, I do. I mean, this could ask this later, but we had focused during budget adjustment, we had talked about the issue in DCF Family Services about the money flow, something that isn't going to show up in budget line items, but that's part of the budget, that money flow, Woodside, Red Clover. And I know I mentioned to our corrections liaison that the Corrections and Institutions Committee is taking up an update on the youth campus, which will not show up in that budget either. And we talked about a heads up to the department about that's something we were going to want to get. And did they get that? They did. Okay.
Whether they'll have it or not, I don't know. But
No, but you did request
Yes.
them to provide that. Okay, great. Then we know we can ask where it is.
You can ask.
Yeah.
Anyway.
Yep.
All right. Any other questions about sort of carrying out? And just so you know, when people come to me and they want to talk about budget stuff, I'm saying, oh, the budget team for that area is,
We've
and I
got
give them the
those
names.
messages.
Well, I'm like, it's not going to do them any good. Just, talk to me about it if it's not something that the team recommends back. So that's, you guys will do the digging into whether these issues have merit or not. So, okay, I think we're done for today. Unless there's any other questions. Comments.